everyone, I'm Waksman, and with me we have Spence, Sherif Sultan, and Ido Weinberg. And we are at the VEITH Symposium. I just came out from a very hot debate on the lipid management of the patients today. And obviously we have different kind of opinions, and maybe we'll just focus on the latest and greatest, and I'll ask Spence to kind of summarize in few words what is your take today on lipid management for our patients.
So there was a lot of talk today about statins, and it's very important to understand that it's not all about pills. Lifestyle is extremely important. The Mediterranean diet was shown in the 60s in the 7-country study to reduce coronary risk so much that on the island of Crete, the coronary risk was 1/15 what it was in Finland. In the 4S trial in the mid-90s, simvastatin reduced recurrent coronary events by 40% in 6 years, and a year later, the Lyon Diet Heart Study showed that the Mediterranean diet reduced recurrent coronary events by more than 70% in 4 years. 40% in 6 years with statin is half the effect of the Mediterranean diet. So doctors are very much underestimating the importance of diet. They're also very much underutilizing ezetimibe. Ezetimibe blocks absorption of cholesterol, whereas the statins reduce formation of cholesterol. The combination is synergistic. Ezetimibe 10 milligrams with atorvastatin 10 milligrams lowers the LDL cholesterol as much as 80 milligrams of atorvastatin, and it should be used much more, especially in patients who are statin intolerant. The PCSK9 inhibitors can reduce LDL cholesterol by 60% and markedly reduce events, but they're extremely expensive. And so we really need to be thinking more and more about diet, Mediterranean diet, ezetimibe, the highest dose of statin tolerated. And when we do that in patients with carotid stenosis, with the aim of obtaining regression of plaque, it reduces events by 80% in 2 years. This is a marked reduction of the residual risk seen in the randomized trials.
So you're advocating both Mediterranean diet and drugs. You're not like excluding drugs.
Right, Mediterranean diet and drugs.
And Dr. Sherif Sultan, we heard from you a completely different view, kind of critic, put the studies on a very high critic. Maybe if you'll summarize your thoughts about the management of patients who had the hyperlipidemia or dyslipidemia.
Very good. In 2008, I published the first paper about the hyperhomocystinemia at the 21st century cholesterol. And I basically said that a tablet per day will not get the doctor away. You have to change your lifestyle. It's the only way forward. Cholesterol is a very important molecule in the body. It prevents infection, prevents depression, prevents a lot of other bacterial problems, viral problems, prevent cerebral bleeds, and prevent cancer. So you start playing with the cholesterol molecule, you start having side effects from this, and this is well documented in a lot of stop trials that have been mentioned today. My whole idea is that there's two types of prevention, primary prevention and secondary prevention. In primary prevention, tablets don't work. The only thing is lifestyle changes. Change your lifestyle, off your couch, start walking, drink a lot of fluid, avoid refined sugar, and you'll do fantastically better than anything else. Secondary prevention, there's a lot of debates about it, and this is why I debate. But in primary prevention, it's very clear. Never take anything from primary prevention apart from changing your lifestyle. And I hope I'm going to not annoy anybody by saying that I don't prescribe statin because there's a lot of things that I don't agree with, not because of my own vision, because of our publication. And what we have seen that the lower the LDL you do, the younger you die, and the higher the LDL, the longer you live. And you could check that in the British Medical Journal on 75,000 patients that we published in 2016.
So Dr. Weinberg, you're seeing a lot of patients with PAD, very robust clinic, a lot of patients with dyslipidemia. What is the rationale? You heard like two almost opposing views. What's your take on that? And also if you can tell us what do you think about the latest data that came with PCSK9 as you alluded in the visit.
Thank you for the opportunity to comment on two great physicians and say what I think. So, the bottom line is I think it depends on the patient in a lot of ways. I think for most patients, lifestyle modifications will not work. I think real life is sometimes stronger than most patients would like to admit, and oftentimes primary prevention is not where we see these patients. I think oftentimes we meet the patients when it comes to secondary prevention, and I think most of us would agree that in those patients there's little argument that medication has been well proven to improve both the quality of life, reduce events, and also reduce mortality. Specifically the latest data that you mentioned, so the PCSK9 data that just came out a couple of days ago at the American Heart Association meeting, the Fourier study, specifically the sub-analysis published in Circulation about 3,000 patients with PAD, we saw that not only was the LDL reduced considerably, but also there was a very robust reduction in events, not only major adverse cardiovascular events, but also specifically limb events with very impressive low number needed to treat, between 16 and 30, depending on the specific indication. So if it wasn't for the price, like you mentioned, if it wasn't for the need for injections, I think those the PCSK9 inhibitors would take a much more sort of front and center place right now. I think, however, right now I think the right way to go is probably robust lifestyle modification, diet, activity, which I'm a huge proponent of, and for those patients in whom that maybe doesn't work and we need to supplement, and obviously statin medications, ezetimibe, and maybe one day PCSK9 inhibitors.
And,
So
and
let me
smoking cessation.
Yeah, but that's a lot of other lifestyle. But and I was advocating that the lower is better with respect to LDL. But again, a lot of things has to be proven on the long run. So let's see if we can come to any consensus. So is there anyone? Can we make it? We have consensus that lifestyle and diet is important. I mean, does everybody agree here?
Definitely.
All agree. Okay. So is there any patient that you would think that he's eligible to get statins or lipid lowering?
Yes, a middle-aged man with a heart attack coming in, they need to take it for the pleiotropic effect for about 9 months to 1 year. I have no problem with that. Patients themselves don't have a compliant with statin, and all the trials showed that within 5 years all of them have done the tablets, and we have a problem with that. And we have to look in this, and I have the numbers.
Dr. Spence?
Yeah, the PCSK9 inhibitor studies have shown very clearly a reduction of events that continues right down to an LDL of 2 millimoles per liter, which is 38, and with no adverse effects. The only creatures on the face of the planet that have an LDL above 1 millimole per liter, which is 38, are lions and humans. We don't need much LDL whatsoever to achieve the functions that Dr. Sultan is talking about.
So we disagree on that. There is a debate, and a lot of people are questioning that part. Maybe my last question to you, Dr. Weinberg, with respect to patients who are struggling with lifestyle. I mean, we all say to them, well, keep your diet, but they don't. Do exercise, but they don't. I mean, most of them, I mean, your patients primarily are not doing it. What is that for you? I mean, what is that you're doing on them on a daily basis?
Yeah, so I think I want to say two things about this. The first is I think that of preventing or not giving a patient medication while we're trying to convince them to improve their lifestyle, I think that could be a common ground that we may agree upon. Because even if we do believe in lifestyle, and I think we do to a point, I think that promoting lifestyle could take time, and not all patients agree with that. So I think that would be a place where we would agree to medicate patients. I think that at the end of the day, I think we all understand that humans are humans, and our patients sometimes do prefer medication. I think in my personal practice, and I think you would echo this also, most patients do comply with statins and other medications that I prescribe. Some of my patients I've been following for many years, and it seems like they're still on the medications I prescribe, or otherwise the requests for renewed prescriptions are truly false, which I don't think they are. So that would be my answer. My answer would be to try to combine it all at all time, and to try to see things through the patient's eyes.
There's a measure that can be used to markedly improve compliance, and we use it in this process that I call treating arteries instead of risk factors. It's a paper from Wisconsin by James Stein's group, the first author was scorecards, showing that if you show patients pictures of their arteries, they are 4 times more likely to be compliant, and that's part of the process that we use in treating arteries.
That scaring effect.
No, it's not scaring, it's motivating. It's personalizing, it's not statistics, it's now personal.
Good.
If I tell a guy, you're 50 years old and you have arteries worse than a healthy 80-year-old, and your arteries got worse last year, he's motivated.
But as you can tell, we cannot get full consensus because this is a very heating debate. I think the debate will continue on. We need to get more data. There will be more data by next year when we reconvene. So stay tuned. That's what we can give you today. I'm sure next year will be wiser and smarter. Thank you very much.
Thank you.
Thank you.
Thank you.